happening. My hellos have been missed.
Yeah. We'll formally start the session.
Yeah,
I
okay.
request
Good
Dr.
evening.
Arya, our Honorary Secretary of Central AHA, to start the session.
Okay. Thank you, madam. Thank you. Good evening. Today, in this webinar of super specialty IAPHA on endocrinology, I welcome you all from my core of heart. I welcome our esteemed guest, OB, EB, and Vice President from CIAP and OB, EB from CAHA. And also welcome all the members attending this wonderful and important super specialty webinar. Now I invite our chairperson, Dr. Hima Bindu Singh ji, for opening remarks and welcoming our guest. Dr. Hima Bindu madam.
Yeah. Yes, sir. Good evening. Once again, on behalf of our the biggest chapter of Indian Academy of Pediatrics, the Central Adolescent Health Academy, I welcome each one of you to this very special, our monthly adolescent super specialty webinar. So as we have seen that we have been celebrating our silver jubilee year throughout since January, and I think we are flooded with a lot of activities, and I hope it's not causing inconvenience to many of us, but we should be enjoying it rather than saying that bari itna hai, bahut kuch ho raha hai. So many programs are happening, but each team is different, and we are not overburdening any team, and all are actively working. Like we have the boy child module is running throughout the country. We have the parent teening course as a workshop we have done, and it was so well attended, so well appreciated. And we are really progressing from just didactic lectures to interactive sessions, including role plays and practical hands-on. Like we are showing them how to really doing the counseling
நாளைக்கு
techniques
phone
and
பண்றேன்.
many really useful things where our pediatricians who want to take up adolescent health in practice in the future are looking forward to this Adolescent Health Academy, AHA, to give them knowledge, to give them practical hands-on experience or some tips, and they are really following us in a big way. Many are joining our academy in large numbers, and we are seeing our membership is increasing as we are doing these activities. So this is how we need to really work, and we are a large, dedicated, passionate.
దగ్గరగా పెట్టుకుంటే వస్తాను.
Chandrelekha
ఇది
garu,
ఎక్కడో పోయింది. ఎస్ అండి.
please mute, madam.
ఓకే.
Yeah, sorry. Yeah. So we need to really keep this pool of passionate doctors together with us, because we are the ones who are doing mostly the community activities under the umbrella of Central IP and AHA. And we go out to the community to help our adolescents, boys and girls, and also guide the parents and the teachers. So with this broad framework, we have come out with very innovative ideas this year, and with the help of my our OB members and executive board of 2025, the team, Dr. Geeta Patil madam, Dr. Sushma Desai madam, Dr. Prakash Arya and Dr. Shamik, and many all EB members. They're doing excellent work. Each one of them have taken up some responsibility. So I'm really proud. We have moved out of the routine topics to adolescent super specialty webinars also. This webinar is also very special since it's
Emma, there is some connectivity issue at your
endocrinology.
Your voice is breaking.
And day in and day out, adolescents, how they are playing.
To the host who is regulating, please just check on Hima's connectivity.
Again back. Yeah.
Yes,
So I
ma'am.
was saying that
Yes.
our chapter is doing so much work, and I think this webinar today will help our pediatricians to empower them on adolescent endocrinology issues, because endocrinology is a core part of adolescence with so many hormones kicking within their bodies. And I really acknowledge the presence of our guest of honor, Dr. Sangeeta Yadav madam, who's actually our past chairperson of APHA and also been keenly interested in adolescent endocrinology. Her expertise is adolescent endocrinology. We know her as a passionate pediatrician, past chairperson, who has added to the legacy of Adolescent Health Academy for what it is today. And she's been a teacher herself, a professor, and a leading Safdarjung Hospital and MAMC. And we have seen her in many roles as the Joint Secretary of IAP also. Madam, we welcome you to give your special message today and all acknowledge the presence of Dr. C.P. Bansal, sir, Dr. Prajapati, sir, many seniors here. All welcome to each one of the participants from all of the country. Namaskar, sir. And over to you, Sangeeta, madam, for your message for today's webinar.
Namaskar to everybody. And I would first of all like to congratulate Dr. Hemabindu Singh as a team leader of Central AHA, along with being supported by Dr. Sushma Desai and Dr. Geeta Patil, who have been before her the chairperson and will be following her, and Dr. Prakash Veer Arya, as well as Dr. Sneha and Dr. Shamik Ghosh, and all the illustrious EB members who are supporting her to take various programs forward. I also acknowledge and do namaskar to Dr. C.P. Bansal, who has been quite instrumental in taking the Adolescent Health Academy forward with great vision. And I would like to, I'm really honored that Hima has called me as a guest of honor. And these are my passions. I started off with endo, moved into adolescent, and adolescent endocrinology is the core part of adolescent development. And I'm very glad that you have picked up this topic of adolescent endocrinology, and it is actually fun doing these workshops because they really empower you how to handle those small little issues which come up related to the adolescent um, growth and development, also which are quite instrumental related to their body image issues, which are also important. And you have got a wonderful panel of our expert, my friends who are there, Dr. Purnima, Dr. Zalak, Dr. Chetan, Dr. Kakali, and I do not know, another name is also
Dr.
there.
Rahul.
Rahul is there, but there is another youth participant.
Youth, one young voice, madam, we have taken Dr.
Yeah,
Tarini.
youth participant, the young
Yes.
voice, no, which you really always insist
Yeah.
upon. And I'm very happy to be here. And the Sudha Rao is there. We have
Yes.
all been contemporaries and been working in endocrinology for quite some time. And she's also your illustrious alumni of Gwalior. I would like to. And the best part is this topic of menstrual irregularities is very important and which needs to be addressed by the pediatricians and the adolescent experts, because at times these girls, they are being brought up by us as a pediatrician, and when they feel a little shy, they're more comfortable with us than going to the gynecologist. So at time, many of you have your spouses as gynecologist, and also sometimes it's not an issue. But in larger public health hospitals and other hospitals, parents are very reluctant to take these young girls to the gynae OPD, OBGY gynae OPD, just in case somebody just comments related to something. So therefore, they are more comfortable with the pediatricians, and therefore we need to be empowered, and we should be aware how to address these issues of these young girls related to menstrual irregularities. And I know you are going to cover up a whole lot of vast issues related to growth, puberty, and other issues which are related to the adolescents during this time. And I acknowledge the presence of Dr. Harmesh also. And sometime back we were all on the webinar related to another topic which had to be, which one has to take forward during this AdolesCon 2025. And thank you very much and best wishes. And Hema, really hats off the way you roll the programs.
Thank you, madam. So nice of you. All of you have inspired us. And yes, we are doing this. The National AdolesCon is also coming. Our Silver Jubilee AdolesCon at Ahmedabad. I welcome all of you as the chair of Adolescent Health Academy. And this is only 2 months away. So many of you are already got involved in many of the workshops and to the scientific program. So let us again come together in celebrating our 25 years of adolescence. Thank you once again, madam. And Sudharao madam will be joining us a little late, and she'll be speaking on menstrual issues. But before she joins, I think we should start with a panel discussion. Dr. Arya sir, I think please introduce our moderator, Dr. Rahul. We have chosen all the young pediatric endocrinologists throughout the country, from across the country. Over to you, Rahul. I hope the program will be useful, interesting, and we are looking forward. Before we start, I think we can take few comments from Dr. C.P. Bansal sir and Dr. Prajapati sir. Dr. C.P. sir, C.P. Bansal sir. So it's a pleasure to see you. I know you're very busy, but then you're making it point to come and encourage us. That really helps. I mean, it really boosts us a lot, sir. Few words from you for our young people who are also there today.
Thank you so much, Dr. Hema, and thank you, respected madam, for your kind words, Dr. Sangeeta madam. In fact, I am here today just to uh, congratulate and convey my very sincere regards to Dr. Sudha Rao. It's indeed a pleasure and pride to tell everybody that she is a proud alumni of GR Medical College Gwalior only,
Yes, yes,
and
sir.
she's from our hometown. So, apart from being this topic extremely important, as rightly been pointed out by Madam, and all of us face problems day in and day out. So, this topic will certainly make us wiser to deal with several issues, right from puberty to concerns about height and so many other issues related to endocrines. And my best wishes to all the panelists and Dr. Hema Bindu Madam also for taking up newer heights to AHA, and all past chairpersons and leaders of AHA. I salute you for your dedication, and I'll not take much of your time between you and the experts. Thank you so
Thank you.
much.
Thank you so much, sir. So Prajapati, sir, would you like to give your comments?
Thank you so much, madam. Actually, I join all these super specialty webinar as a student,
Hey,
and
so
I
nice.
really appreciate that you have taken such important topics. And after so much of administrative work and the interest in adolescent, I want to be a part of all the things. It's a great pleasure to listen to Dr. Sangeeta Yadav. Uh, I started in MMC a lot of time with madam and really learned a lot. And you and madam, your team, Dr. Geeta Patel, Dr. Prakash Veer, and all the panelists and all the experts. Thank you so much. And I would just like to listen to it. Thank you so much.
Thank you, sir. Thank you. So we still have, in spite of so many
Thank you,
programs
Dr.
going on, we have at least 70, 80 attendance, and we shoot up to 150 to 160. The boys module, we are seeing recently, we shot up more than 160. And that's a really great encouragement for all of us. So over to you, sir. Let's have academic, interactions. Please introduce our moderator, Dr. Rahul Reddy,
मैडम
sir, to
बिफोर
start
दैट
the
है ना
session.
डॉक्टर गीता पाटिल मैडम भी हैं उनसे भी है ना थोड़ा
Yes,
ब्लेसिंग
yes, sir.
है
Word of
गीता पाटिल
advice.
मैडम प्लीज
Thank you, Prakash Vidarya sir. And
Yes,
we
madam.
know that endocrinology plays a critical role in adolescent medicine.
Right.
So that our main chunk of patients is endocrinology, menstrual irregularities, and Dr. Sudha Rao, I have heard her last Sunday in Karnataka Endocrinology
अरे
Conference.
वाह
Okay.
And it was a pleasure. She has simplified such a difficult topic. I am not going into the details of that. And I definitely vouch that she will be definitely talking on these menstrual irregularities and clarify our many doubts. And these all youngster panelists, Rahul Reddy, Malaika, and Purnima also. Purnima, I know her very well. Dr. Zhalak, Chetan Dave, Kakali Roy. I think all of them are going to enlighten us about the common
All different
adolescent.
zones of a country.
Yes,
Mm.
great. And
Yeah.
our main important thing, we have got a youth voice everywhere, which
Right.
makes
Yes.
our session very interesting.
Yes.
So Tarani is there. Thank you very much for giving opportunity. I want to learn. So basic
Yes,
main thing,
Geetaji,
I think
thank you.
pranam to Sangeeta Yadav, Dr. C.P. Bansal, Prajapati sir. All of them are there to bless us. That is great. And especially Dr. Himabindu madam has taken so much efforts for the super specialty webinars which are going to benefit everyone. Thank you very much.
Thank you.
Thank you, Geetaji.
Thank you. And now I invite Dr. Rahul Reddy C, the moderator of today's webinar, for further proceeding. Dr. Rahul Reddy done his MBBS from Usmania Medical College, Hyderabad, his diploma in child health and MD pediatrics from Christian Medical College, Bello. Done his fellowship in pediatric endocrinology from National Institute University Hospital, Singapore. He is presently working as a consultant pediatric endocrinology at Ankura Hospital, Hyderabad. Over to Dr. Rahul Reddy.
Over to you, Rahul, to introduce your panel.
Yes, ma'am. Respected Himabindu ma'am, senior dignitaries from IAP and AHA, Sangeeta Yadav ma'am. I'll try to keep it interesting and we'll have a good discussion on adolescent endocrinology topics. I'll introduce my. Are you able to hear me, sir? Just
Yes,
checking.
yes, yes.
Prakash, sir.
Yes.
Yes, sir. Okay, okay. So today's panel discussion with me today, I have a co-panelist, Dr. Malvika, co-moderator, Dr. Malvika Srijit. She's a consultant pediatrician from Baby Memorial Hospital in Kannur in Kerala. She'll be discussing a few topics, whereas I'll be going through some more. Among the panel, we have a youth member with us, Dr. Tharani, who is a recent MBBS graduate from SVS Medical College, Telangana, and currently working at Government Medical College, Ramagundam. She'll be asking us and telling us a few of the common questions that adolescents and young adults have regarding endocrinology. Then we have Dr. Zalak, who is a pediatric adolescent endocrinologist at Endocare for Kids. We have with us Dr. Purnima, who is a consultant at pediatric endocrinologist at Rainbow Children's Hospital in Bangalore and also Medha Specialty Clinics. She is a well-known pediatric endocrinologist with national and international publications. Pediatric endocrinologist at Rajkot. He's working in the Hormone Clinic, and he's done his fellowship in pediatric endocrinology at Kanpur, and then for fellowships in Liverpool and Cleveland. Houston, professor at NRS Medical College in Kolkata. She's done her MD Pediatrics from ICH Kolkata, followed by senior residency and pediatric endocrinology training at AIMS New Delhi. I welcome you all co-panelists and also the co-moderators for this session. I pass over the mic to Malvika Srijit, who will be moderating the first few topics. Welcome, Dr. Malvika.
Thank you, sir. Hello. So a very good evening to everyone and a very warm welcome to this month's webinar on common problems in endocrinology. We are truly honored to have an esteemed panel of pediatric endocrinologists with us today. Thank you all for joining us, and we look forward to an engaging and enriching discussion. So going on to the first topic for the day, which is growth. So Dr. Kakli, sir.
Dr. Malvika, one second. I'll just also ask Dr.
Yes.
Tharani, as she's our first,
Oh, sure.
she's our youth member, regarding what she thinks are common pediatric endocrinology or hormonal issues faced by young adults and adolescents. Dr. Tharani, if you could unmute yourself and please let us know from your perspective so that we will answer them through the session again. Dr. Tarni, if you can unmute yourself and then you can let us know your perspective so that we can discuss all those things in our session today.
Yes, sir. I'm here. Am I audible, sir?
Yeah, your video,
Yes,
Tarini.
Yeah. Yes, ma'am.
Yeah.
Good evening, ma'am. Good evening to all the
Good evening.
respected dignitaries and the stalwarts. Firstly, I would like to thank Dr. Himabinder Singh, ma'am, our beloved principal, ma'am, for giving me this opportunity to appear on this webinar. And it's truly honorable. Like Yeah, I'm very grateful for this opportunity to be to be here against all the esteemed and very experienced top doctors from all over the country. So, firstly, I'm going to discuss about all the common problems, all the common doubts which adolescents and their parents have these days. So, firstly, there are basically three major concerns regarding endocrine disorders. The first thing that comes to my mind is lifestyle modifications. Uh, it is widely acknowledged that uh, all the adolescents in the previous generations have been healthier comparatively. When you look at teenagers in the past and now, you will be able to appreciate the difference in a sense that endocrine disorders have become more rampant these days than compared to back then. So I think one of the major reasons for this is because of rapid industrialization and also digitalization, which has increased exposure to all the harmful substances. For example, radiation exposure, and then we have so many chemical disruptors which basically interfere with the hormonal balance and create endocrine disorders. So I think primarily the discussion should be around lifestyle modifications, so that so that half of this problem can be solved right before it even begins. And also, it's very important to identify the signs and symptoms, which most people are not aware of, unfortunately. And even those who are aware of are unable to make any modifications because of the given competitive environment which has been created for the adolescents. Nobody is able to make time for healthy practices. So I think it would be great to discuss all the lifestyle issues.
Yeah, sure. We'll go through those topics in the session that we have now. We'll take it forward, the panel discussion, and the questions will be addressed in the panel discussion that we go through now. Thank you, Dr. Tharani.
Yes.
Yeah. For the yeah. Dr. Malvika, you can carry on with the panel discussion again.
Okay. Yes, so a very good evening. So going on to the first topic of the day, which is growth. The first question is to Kathleen, ma'am. When should an adolescent be considered short?
Yeah, thank you. Good evening, everyone, and thank you to IIP for giving me this opportunity. So, an adolescent is considered short when the height is more than 2 standard deviations below the mean for the age and sex, and which is plotted on the standardized growth chart. So, this is by definition. So, whenever we get an adolescent short, so the main things which comes in our mind, whether this is physiological or whether this is pathological, we cannot miss any pathological short stature or short adolescence, whereas we should not do over investigations in the physiological short stages. So in this case, the three tools which helps us very much and which is very easily available, that is a growth chart, the bone age, and the SMA stagings. Like if a child is short, we are plotting on a growth chart, standardized growth chart for the appropriate for the age and for the gender. If the child is short, that gives us the idea that child is short for the population because the growth chart is for the population standards. So next, we should look for whether the child is short for the family. So if we calculate the mid-parental height and we can calculate the target height, then if you compare, so if the child is not short for the family, then this is a familial short status, which is a physiological case. We need not to jump for the investigations or worry about that. And if the child is short for the family, then the next comes the next most important cause of the physiological short status, that is the CDGP, that is a constitutional delay in growth and puberty. So we must rule out CDGP before going for the other investigations or pathologicals. So in that case, we will ask for, so whether the child is short for the bone age. Bone age is very important. If the child is not short for the bone age, that is most likely going for the CDGP. So CDGP, where the bone age and the puberty both are delayed. So usually the final heights are normal. There is just a delay in the growth spurts and the pubertal milestones. And the next comes the SMA staging, which is very important. If we are if we are dealing with three girls, both are of 12 years, but both are at different stages of the puberty, then the final height might get affected. Like if the child is on the B2 stage, we expect a gain of the final height of around 20 to 25 centimeter. So three girls, both are 130 centimeters. So the girl who is on the second B2, we expect the final height plus 20, like almost 150, 155. If the child is in the B4 stage, we expect a height gain of around 10 centimeter and very close to menarche. And once a child is menarche done, we expect not more than 5 to 8 centimeter. So these three tools which helps us very much, that is the growth chart, appropriate growth chart plotting, the bone age, and the SMR staging.
Thank you so much, ma'am. Going on to the next question. So this is to Dr. Chetan. Until what age do boys and girls typically grow, sir? And how is the bone age used to estimate the final height, like ma'am had mentioned?
Yeah. Hello, good evening, everybody, and thank you, Hima Bindu ma'am and the team. Hi to Rahul. So the age till which a person can grow does not depend on the chronological age, but it depends on the bone age. So definitely bone age holds an edge over chronological age. And regarding the chronological age, usually when boy reaches up to testicular volume of 18 to 20 ml, at that time the bones become fused for the boys. And for the girls, whenever first period, that is menarche happens, girl usually grow after first period to up to 6 to 8 months. That is approximately 1 to 2 inches. So to depend, we need to go for the pubertal examination as well as bone age to see how much height potential is less. And nowadays, few softwares are also available in which we have to just upload the X-ray and they will give you that how much height potential is remaining. So definitely it's the bone age, not the chronological age, which decides till what age a child can grow. Thank you.
Thank you, sir. Going on to Zalak, ma'am. What are the common indications for using the growth hormone in adolescents, and until what age can it be administered?
Good evening, everyone. Thank you so much for the opportunity. Moving on to this question. There are FDA approved indications of growth hormone therapy. Like we know when there is growth hormone deficiency, we have to give growth hormone therapy. Turner syndrome, Noonan syndrome, then any SPA child who has failed to catch up, Prader-Willi syndrome, idiopathic short stature. So all these are FDA approved, chronic renal disease. So all these are FDA approved guidelines. Sadly, we still get children. Sadly, we get children who come very late to us for concerns of short stature, because at times they are told that as the child will grow up, they'll be okay in the height. So those kids are what we call as constitutional delay in growth and puberty. Not all children have CDGP. So we should know what is CDGP and when can we tell them कि बच्चा बड़ा होगा जैसे जैसे height ठीक हो जाएगा. So this is also a myth. When we talk about adolescent growth hormone therapy, all the FDA approved indications, we continue growth hormone therapy even during adolescence. But one of the great concerns these days is precocious puberty in girls. We have seen that girls or boys, but we often see in girls that there is increased incidence of precocious puberty and early menarche. So when this happens, we have to give GnRH analogs to stop the puberty and ongoing bone age progression. And we give growth hormone therapy so that the height outcome is better. So during adolescence, this is also an indication to give growth hormone therapy. When we talk about till what age it can be administered, growth hormone therapy has to be given in different doses for different conditions. We have daily therapy and we have weekly therapy also now. It's quite safe. Parents are really scared of giving injections, but we always explain them benefit and the risk, and then we tell them to start. We know that many government hospitals even provide growth hormone these days. Growth hormone therapy should be given till we expect that the child should reach the target height, adult target height. So once the child reaches, we can then stop, or to stop, we also do the bone age. We know that if the epiphysis fuse, then we do not expect much gain in height. So around 15 years of bone age, and when we give growth hormone therapy and in a year we get less than 2 centimeter of growth velocity, that is also an indication to stop the growth hormone therapy. When we talk about growth hormone deficiency, they say that we should continue growth hormone therapy even in adulthood at low doses for metabolic benefits, for the bone mineral density, the body composition, the cardiac issues. So giving growth hormone therapy even in adulthood, if it is growth hormone deficiency, is beneficial. Thank you.
Thank you so much, ma'am. Going on to Dr. Purnima. What are the red flag signs in adolescents with short stature, and when can they be referred to a pediatric endocrinologist?
Good evening, everyone, and thank you, Dr. Himabindu ma'am and the team for giving me the opportunity. Coming to the red flag signs, the infancy, childhood, and puberty model explains us about the factors which is influencing the growth. So, wherein the infancy is going to be predominantly with nutrition, and childhood is predominantly the hormones like growth hormone and the thyroid, and the puberty is being influenced during the puberty phase. Testosterone and estrogen influences the growth factors for the growth of these adolescents. Now, considering this background, when an adolescent, which comprises from 10 to 19 years of age, and when they come to us to an OPD with not gaining adequate height from past a year or two, and along with that, if there is also associated weight gain, then it is predominantly for endocrine conditions. And among the most common endocrine conditions that we come across is hypothyroidism and Cushing's. So hypothyroidism, if there is any history of constipation, lethargy, cold intolerance associated with inadequate height gain as well as weight gain. And in Cushing's, they do have the weight gain as well, along with inadequate height, velocity, as well as there will be mood changes in and acne in and Cushing's child. And a growth hormone deficiency child, generally they come with decline in the growth velocity, which is noted over a period of time. Now, apart from this, if there are any chronic systemic infections pertinent to particular infections, so those are the glaring features which could be identified. And chronic inflammatory conditions like rheumatoid arthritis or inflammatory bowel disease, chronic drug intake with steroids use, and eating disorders, particularly in adolescents, anorexia nervosa and bulimia, wherein micronutrient deficiencies could be identified in them. Now, coming to the referral to a pediatric endocrinologist, if the child's velocity is less than 4 centimeters in a year and the child was growing well and there is downward crossing of more than 2 centiles below the mean, and if there is no evidence of pubertal signs noted by around 13 years in girls with respect to the breast development or 14 years in boy with regard to the testicular volume, tells us that the child is requiring an endocrine evaluation to be done. Thank you.
Thank you, ma'am. That was truly an enriching session on growth. Now we move on to the next topic, which is puberty. Ma'am, Dr. Kakli, the question is to you. What are the age cutoffs for diagnosing precocious puberty in boys and girls, and what are the earliest signs of puberty?
Yeah. So the precocious puberty is said when the appearance of the secondary sexual characters is before the age of 8 years in girls or before the age of 9 years in boys. And if you say the earliest signs, in girls, the earliest sign is the development of the breast or the thalarchy, which is followed by the puberty, growth spurts, and the menarche. And in boys, the earliest sign is the testicular volume, which is more than 4 ml, or the length of the testis, which is more than 2.5 centimeter, followed by the penile growth, puberty, and the growth spurts. And the central precocious puberty, that is the activations of the hypothalamic pituitary gonadal axis, which is most common in the girls. And the peripheral precocious puberty is mostly due to the hormone secreting tumors or the congenital adrenal hyperplasia. Thank you.
Thank you, ma'am. Going on to the next question to Dr. Zalek. When are the pubertal blocking agents indicated, ma'am?
Yes. So there are two types of puberty: central precocious puberty, central and peripheral. Now, when we talk about central precocious puberty, we know it goes in the proper manner, but it's little earlier in the age, and the pace is also faster. So when, as we know that when there is precocious puberty before 18 girls and 9 in boys, we start pubertal blocking agents, and they are GnRH analogs. Now, why do we use analogs or agonist? Why do we use GnRH agonist? Initially, there will be flare and then desensitize, and GnRH secretion then stops. GnRH is secreted, LH and FSH are pulsatile. So what happens when we give a dose of GnRH? There is a continuous exposure, and that desensitizes the pathway. So then there is no secretion, and hence the sex steroids are also not secreted. So GnRH agonists are used, and we most commonly we use leuprolide. There is triptorelin, hysterelin, but we use leuprolide, which is very common. And according to weight, we start the leuprolide injection, which has to be given IM. And the other is peripheral precocious puberty. Like if there is hypothyroidism, there can be ovarian cyst and Van Wyk-Grumbach syndrome. And we have McCune, where again there is recurrent ovarian cyst. So treating the underlying condition, even congenital adrenal hyperplasia can have precocious puberty. So treating the underlying condition of CAH hypothyroidism solves these issues.
Thank you, ma'am. Going on to the next question to Dr. Purnima. How can this precocious puberty be differentiated from premature tilak?
So when the onset of the first sign of puberty, that is the breast bud before 8 years of age, and if other puberty followed by other pubertal signs like appearance of the pubic hair, then axillary hair, and then the vaginal mucosa becoming pale pink, and associated height acceleration noted, in which there could be a crossing over of centiles, more than 2 centiles above the mean. In that case, this is a precocious puberty. Whereas in premature thelarchy, breast bud is noted at two different phases, that is at 2 to 4 years of age and at 6 to 8 years of age. But there is no evidence of other pubertal signs progressing in this entity. And simultaneously, the height velocity will remain along the same centile in the growth chart. And when we do a bone age for both of these conditions, bone age will be equal to chronological age in premature thelarchy, whereas it is advanced by more than 2 years compared to the chronological age in precocious puberty. Now, precocious puberty requires evaluation and the treatment, whereas premature thelarchy is a benign and self-limiting condition which requires to be kept under follow.
Thank you, ma'am. Going on to the next question, it's to Dr. Chetan. So, in boys with delayed puberty, what are the clinical features which suggest a delay in the constitutional delay of growth and puberty, and how can it be distinguished from hypo or hypergonadotropic hypogonadism?
Yeah. So if we start with the history, CDGP will have typical family history of delayed menses in mother or delayed shaving in father. Along with that, the parents will say that our boy is typically growing slow since the early childhood because it is constitutional delay of growth as well as puberty. So the boy might be well below the target MPH, that is mid parental height range. So this is the history. Now if we talk about the clinical features in CDGP, as there is growth is also delayed and puberty is delayed, there won't be any pubic hair, and this is the most important sign which differentiates it from hypogonadotropic hypogonadism. While hypobole will have normal growth and he will be well within the MPH range. Plus, as we know that adrenarche is a total different thing. So pubic hair as well as axillary hair will be present normally in case of hypo. If we talk about investigation, CDGP will have good response to GNRS simulation test, while hypo patients will have very low LH and FSH response as compared to those with the normal response in CDGP. So typical history, growth chart plotting, presence or absence of pubic hair as well as response to GNRH simulation test will differentiate CDGP from the hypo patients. Thank you.
Thank you so much, sir. The last question is to Dr. Purnima. In a girl who has not attained menarche, then when should the primary amenorrhea be diagnosed and what are the common causes?
So when there is absence of the first menstruation by 15 years of age, in the presence of normal growth and secondary sexual characteristics, or not attain menarche by 15 years of age post 3 years of uh, 3 years of telarchy phase. Now the causes can be broadly classified as structural, endocrine, and non-endocrine causes. So in the structural category, Mullerian agenesis, imperforate hymen, vaginal agenesis, and MRKH, that is MRKH syndrome. So these are the ones which do not have menstruations, but otherwise has all the other pubertal signs. Now, when coming to the endocrine cause, most common is the CDGP, which is a late bloomer, and multiple pituitary hormone deficiency, hypogonadotropic hypogonadism, and DSTs, particularly the complete androgen insensitivity syndrome. And among the CH variants are 17 alpha hydroxylase and 1720 desmolase are the conditions which should be considered. And among the non-endocrine conditions, anorexia, chronic systemic illness are the conditions which can be considered with the primary amenorrhea, and also Turner's syndrome and Noonan syndrome and hypothalamic pituitary disorders like craniopharyngioma and prolactinoma are the conditions, and post chemo and post radiation therapy adolescents do present with primary amenorrhea.
Okay, thank you so much, ma'am. That was a wonderful, informative session on puberty. Now we're ready to move on to the next segment of our discussion. Over to you, sir. Dr. Rahul, sir, will continue the session.
Hi everyone. In this session, we'll be going through some of the common questions we have about PCOS and few more topics later. First, I would like to ask Dr. Purnima ma'am, what is this risk of PCOS that we generally give the term in adolescents? We generally don't use PCOS so much, but we use the term risk of PCOS in these adolescents. And how do these features differ from in adolescents differ from those in adults, the PCOS features? Could you please give us a few words and explain us about them?
So, adolescence comprises 10 to 19 years of age. So, according to as per 2023 International Evidence-Based PCOS guidelines, it is mentioned that the criteria of adolescent PCOS has got two criteria, that is menstrual irregularities, which means in the first year, more than if the adolescent has not attained the menses for more than 90 days, or in the first 1 to 3 years of post-menarche, if the cycles are within 3 weeks or more than 6 weeks, it is considered as irregular. And from 3 years post-menarche till the menopause, if it is less than 3 weeks and more than 35 days or less than 8 cycles per year, is considered as menstrual irregularities. The other criteria is hyperandrogenism, which is clinical features like severe acne and hirsutism, and biochemical evidence of testosterone levels being high and DHEAs. But here, the ultrasound has no role to identify the ovarian morphology, because most of the microcystic ovaries are seen in an adolescent, particularly in the early first 3 years of the post-menarcheal age, which is easily confused with PCOS. Now, with this background, the risk of PCOS in an adolescent is mentioned if one of the two criteria is present. That is, either there should be anovulation or menstrual irregularities, otherwise called menstrual irregularities, or there should be hyperandrogenism with clinical or biochemical evidence. But the difference between the adolescent and the adults is adolescents' hyperandrogenism requires severe acne as well as hirsutism features with a criteria of more than 4 to 6 as per modified Ferriman-Galway score. Whereas in adult PCOS, there is female baldness with mild acne and hirsutism. So that is a difference. Whereas adult PCOS has another additional criteria of having an ultrasound features of ovarian morphology as well as raised AMH levels, which cannot be taken into consideration for adolescents.
So what you're telling, ma'am, is that ultrasound as such
Ultrasound is
does not have
not
much role, and
not required to
just
be
a
done
very
for an adolescence.
correct, ma'am. And also regarding the features, sometimes when they're early, we call them as risk of PCOS when they have a few features, and then they need to be longitudinally followed up to see if they develop PCOS
Yes,
and
so mainly risk of PCOS need to be followed up and see whether they develop the features of PCOS. That is particularly 8 years post menarche is what we consider it as PCOS. Until then, they require follow-up and doesn't require any medications.
That's a great message, ma'am. So it's not good to label 14-year-old, 15-year-olds as PCOS and do ultrasound and see polycystic kidney ovaries and then giving the parents worry and the child worry. We should guide them properly in this adolescent age group because PCOS may be overdiagnosed in this age group, is what you're saying. Yes.
Yes, true.
Next question
Thank
is
you.
to Dr. Kakali. What investigation would you advise in adolescents with signs of PCOS? And what is the role of ovarian ultrasound? So we have pediatricians now with us in this session. So ultrasound ovary is easily available and investigations as well. Now, as a pediatrician, what they should do, and as a pediatric endocrinologist, what you should do, what you will do.
Uh, So, as we have seen, recently the international guideline of the diagnosing the PCOS has restricted only two. That is the presence of clinical or biochemical hyperandrogenisms and the persistent anovulations or menstrual irregularities. So, the key or cornerstones of the PCOS is the hyperandrogenisms, and the source of the androgens are either the gonads, that is ovaries, or the adrenals. So the main androgen is the testosterone. So I look for the testosterone, evolution of the testosterone. And in these regards, the free testosterone is more sensitive because the testosterone binds to the SHBG, the steroid hormone binding globulins, and the remaining free testosterone, which is available for the actions. So the estimation of the testosterone, free testosterone, SHBG, and then I would like to look for the DHEAs, which is a androgen from the adrenals. So the DHEAs is usually increased mildly in the PCOS, but if it is very high, then I would look for the adrenal pathologies like adrenal tumors or something else. And the important thing that is the LH and FSH ratio. So the LH and FSH, which is secreted from the hypothalamus, from the pituitary, they act on the theca and the granulosa cells of the ovaries, and from the theca cells, they secrete androgens. So if the LH-FSH ratio is more than 2:1, it supports the diagnosis of the PCOS, but not diagnostic for the PCOS. And whenever an adolescence is coming with the features of the PCOS, we have to rule out the other mimickers like the non-classical CH. For that, we would like to do for the 17 OHP. And these adolescents are typically of the lean phenotype. They have the early puberty. They might or might not have clitoromegaly. And if the hirsutisms and hyperandrogenism, these are very rapidly progressive or very severe, we should keep in mind if they're associated with any Cushingoid features, we should look for any adrenal tumors. And also we should evaluate for the thyroid hormone and the prolactin because hypothyroidism and hyperprolactinemia can cause menstrual irregularities. And on the other hand, the one most important thing that is a metabolic syndrome. Metabolic syndrome and the PCOS in adolescence is very much have significant overlap and interconnected. So we must look for the metabolic screening, that is a fasting blood sugar, fasting insulin, OGTT, HbA1c, the lipid profiles, these things we should be done for the biochemical evaluations. And the most important thing, that is ovarian ultrasound, ovarian imaging, that Dr. Purnima has very nicely explained. So the name, that is the polycystic ovarian syndrome, the name is based on the polycystic appearance of the ovary. But now in case of the adolescents, this criteria has been removed, because polycystic ovarian appearance, we say when there is an increase in the volume of the ovary or increase in the follicles and the cyst in the ovary. So both these are physiologically, might be physiological in adolescence, because the ovarian volume might increase in the puberty, and the follicles are also expected to increase. So one difference in this is, in physiological, the follicles are usually centrally placed, whereas in the PCOS, these are mainly peripheral. So the latest guideline has removed the criteria of doing USG during the 8 years of the following menarche. And the ovarian ultrasound is indicated in the adolescence or within the 8 years only when we expect some ovarian tumors, like over androgen secreting ovarian tumors. So nowadays, within the 8 years of the menarche, ovarian USG, polycystic ovarian appearance is not diagnostic and not recommended.
Yeah, wonderfully said, ma'am. You mean we should look at the other PCOS mimics as well, like you mentioned, the CAHS, the Cushing's,
Yeah,
the tumors, which we should not be missed, and just labeling them as
yeah.
PCOS is wrong. We should do a workup, and then if at all everything, depending on the overall scenario, we should give them a risk of PCOS diagnosis, or if later on, then PCOS. Nice, ma'am.
Yeah,
That's very
and we definitely should not rush to which already explained by Dr. Purnima, that PCOS. We must follow up at least for
sure.
2
Thank
to
you.
8. Thank you.
Dr. Zelak, one of the common things that teenage girls or adolescents have worry is excessive hair in the body, in the upper lip, in the beard area, with the other areas of the body as well. So, can you please tell us what is hirsutism and what is hypertrichosis? How is it different? Because hair growth can be confused, uh, which is normal, but confused with hirsutism. And also, what are the common causes of this hirsutism problem in girls, which is seen?
Yes. So hirsutism is a coarse terminal hair, and which is usually the male pattern distribution, like the upper lips and chin, and the chest, upper back. So this, and how do we, as Purnima ma'am already said, that it is according to the modified Ferriman-Galway score, that we see and tell them it's mild or moderate, severe. And hypertrichosis is a fine hair, fine vellus hair, and usually it can be it's all over the body. So hypertrichosis and hirsutism, this is a difference. That will be a fine vellus hair, and this will be the coarse terminal hair. Now, the common causes of hirsutism are PCOS, polycystic ovarian syndrome. But during puberty also, mild hirsutism is common because androgen secretion is seen. So mild is common, but when it is severe, it keeps progressing with symptoms, other symptoms of virilization like clitoromegaly. All this is abnormal. So non-classic congenital adrenal hyperplasia, polycystic ovarian syndrome, any androgen secreting tumor, all these are the causes of hirsutism. And if it keeps progressing and the score is more, we definitely have to evaluate for the causes of hirsutism in adolescent girls.
So, yeah. So, would you like to tell the pediatricians that there are some causes which need to be evaluated in all cases of hirsutism, and then say if it's normal, then call it idiopathic?
To call it idiopathic, it should be a diagnosis of exclusion.
Hmm. So,
So, yes.
yeah, so it's important to evaluate them. That is what we
Yes,
can
it is
say
very
from
important.
what you have
To tell
said.
it idiopathic, we have to, it is a diagnosis of exclusion. So we have to rule out all the other causes.
Right. Thank you, ma'am. Next is to Dr. Chetan. Acne is a very common complaint in teenage girls and adolescents, but when should this acne be considered pubertal and when it should be looked for secondary causes, which is hormonal causes, which need to be treated or which need further medication hormonal wise? What would you say, Dr. Chetan, regarding this?
So acne is observed during pubertal development in both girls and boys due to hormonal imbalance between male hormone and female hormone. Any severity or any you can say any duration apart from this pubertal development should be considered as abnormal. Like if any girl develops acne before the onset of puberty, then definitely this is extra androgen which is secreted from the girl's ovary or maybe adrenal. So any acne before puberty, acne which is nodulocystic, which is severely increasing in nature, acne which is associated with hirsutism, acne which is associated with clitoromegaly, acne which is associated with hypertension, and acne which is associated with increase in the weight are suggestive of any other secondary causes and should be thoroughly evaluated.
I think very wonderfully put, Dr. Chetan. So most importantly, you also said that when you have 4 years, 5 years with acne, then it could be some androgen secreting tumor from the adrenal or in the gonads. So those things. And in teenage girls, which is more common in the acne, then you talked about all those severe acne, the frequency, the other coexisting things to look at, the clitoromegaly and all the other things that you've spoken about. Thank you so much for that. So PCOS is a very difficult topic to discuss, to understand, to treat. Our panelists, four of them have really put it across very well and made it very easy for us to understand. Thank you so much for that. Going on for the next topic, we will go on to obesity. Dr. Zelak, common problem, obesity all over India, all over the world. What screening tests should be conducted to detect complications in these obese adolescents, obese children?
So it's said that 80% of adolescents, if they are obese, 80% of them will be obese in adulthood. That is why addressing them during this period is very important. Lifestyle modifications holds a very important role. When we talk about screening test, obviously we look whenever we see the child, when we examine, acanthosis has to be looked at. Doing insulin levels does not have much value, but yes, doing oral glucose tolerance test, fasting blood glucose, giving glucose 1.75 gram per kg, maximum 75 gram, and doing postprandial, like post glucose levels, blood glucose level, and doing HbA1c is important. SGPT, we know that non-alcoholic steatohepatitis, also called as fatty liver, is very important. So doing SGPT levels, lipid profile, so to rule out dyslipidemia. As we know that the diagnosis of metabolic syndrome, we know that the waist circumference plus any one of these, hypertension, triglyceride levels, LDL levels, the blood glucose level, any two of these plus the waist circumference. So looking at all these, and also important is taking blood pressure of this child. And the other reports which we do the routine workup, but added on is the SGPT to blood fatty liver, lipid profile, blood glucose levels, OGTT and HbA1c, and a thyroid profile. TSH can be mildly elevated, but always remember it is not the cause of obesity, it is due to obesity. It is the effect of obesity that TSH is mildly elevated in obese adolescents. So do not treat it. Look wisely and then decide whether to treat or not, but it is usually the effect of obesity. Also, asking for snoring, ruling out obstructive sleep apneas, whether the child has sleep apnea is important. So these are the screening tests to be done to rule out the complications.
Thank you, Dr. Zelak. Dr. Kakali, we have a very interesting question for you. So everybody wants to know what is recent advances in medications for obesity, whether we can give pharmacological treatment, whether we can give the new medications. So can you please tell us something about what's there for adolescents in terms of medications treatment? Yes.
So, managing obesity is extremely challenging, though the cornerstone is the prevention and the lifestyle modification. But the pharmacotherapeutic roles is very interestingly being like tried, and these are in market and in use. So these are indicated, typically the pharmacotherapies are indicated in more than 12 years of the age. And these we consider for pharmacotherapy when the BMI is more than 95th centiles with significant comorbidities, or the BMI is more than 120% of the 95th centile, more than 120% of the 95th centile. And when the lifestyle intervention has failed, at least for after 6 months of trial, and there is significant, and we should consider the physical and psychological preparedness of the child. So the which is very known and which has been used, that is Orlistat, that inhibits the gastric lipase and inhibits the gastric the fat absorption, and thus causes steatorrhea. So it has been used in children, but the effect is very mild, not very significant. The effect in terms of the reductions in the weight or reductions in the BMI. And we should keep in mind that since it is prohibiting the absorptions of the fat, we should supplement with the vitamin A, D, E, K. And then, which is very important and very much being used and quite safe, that is a GLP-1 receptor agonist. So GLP-1 is an incretin hormone which is produced in the duodenum in response to the carbohydrate or in response to the food. It has two mechanisms. One thing is this promotes the satiety and suppress appetite, and it slows the gastric empty and it increases insulin secretions. So the liraglutide, which has been in use for 5 years, so it is a daily subcut injection. The dose can be maximum up to 3 mg. And the liraglutide, the response in terms of the weight and BMI reduction is around 5 to 7%. So Orlistat and liraglutide, they are not very effective in terms of like durability, particularly in liraglutide. Following stoppage of the injections, there is a rebound increase in the fat or the obesity, and the effect is not significant in terms of the BMI, and the daily injection is also not very convenient. So now what is very in trend, that is the semaglutide. The studies have shown there is a 16% decrease in the BMI, which is quite significant and quite good. So, and it is very convenient in terms of it requires a once weekly injections. And so this has been recently approved by the FDA, and all these drugs are for more than 12 years. And the another drug that is the MC4 receptor agonist, that is a setmelanotide, which is indicated in more than 6 years of age. That is particularly for the monogenic obesities, not for the common polygenic obesities. So these are the main drugs, and I would like to mention about the phentermine and topiramate, which was approved by the FDA but now has been banned because it is a centrally acting drugs which suppress the appetite, and it causes the side effects, like it can cause a suicidal, because it acts in the same center where it's the reward centers. So this might cause a psychological problems or the suicidal tendency. So now this has been banned. So mainly Orlistat and now semaglutide, which is being used in pediatric populations. And the other drugs which are not anti-obesity but are being used in obesity, like metformin in case of the type 2 diabetes or PCOS. The growth hormone is used in the Prader-Willi syndrome, which acts very good, and octreotide we use in case of the hypothalamic obesity. And nowadays, the oral GLP is also, oral GLP-1 analog is also where in the going in the phase 3 trials. That is, if this comes into market and if it is processed, that will be very helpful and promising. So, and but one thing which we have to keep in mind, that pharmacotherapy always should be adjunct with the lifestyle modifications.
Right. So, yeah, a lot of pediatricians wanted to know what's happening with semaglutide and the recent oral medication. So, thank you for giving us some brief input into that. That's really helpful. Then we come to the last, we'll put it as the last 3 questions, because again, we have ma'am's topic, Sudha ma'am's topic. We won't want to eat her time. So, let us discuss these last 3 questions, cutting short a presentation of the panel discussion. So, among the gynecomastia, what are the red flags of in boys with gynecomastia, and which investigations should pediatricians consider and pediatric endocrinologists consider? So, ma'am, Purnima, ma'am, what's normal and when should we start worrying and what are the red flags?
If a breast
Purnima, ma'am, are
enlargement
you
was
there with
noted,
us?
yes, I'm there. Am I audible? Am I audible?
Yes, yes, ma'am. Yes, ma'am. Yes, ma'am.
Yeah, thank you. Thank you. So, if there is a breast enlargement noted in less than 9 years of age in a boy, that is the prepubertal, or postpubertal beyond stage 4 in boys, then it is considered pathological and requires evaluation to be done. Generally, gynecomastia is seen in boys between stage 2 to 3 and then it disappears. It's a self-limiting condition and it resolves on its own. If the breast enlargement is unilateral, more than 4 centimeters in size, and persists for more than 2 years duration, and this requires evaluation to be done. And investigation wise, the first and foremost, we do a screening test in terms of thyroid function test and liver function test and the renal function test. And other endocrine hormonal assays that we need to look at is LH, testosterone, estradiol, DHAs, as well as HCG.
Wonderful, ma'am. Yes, and prolactin as well, I think. Yeah. So we've given a very brief and clear description of that. What are the red flags in boys? Very important 4 points that you've put. That's really grateful for that, ma'am. And next question is, Dr. Chetan, what is the natural course of pubertal gynecomastia, which is very common? Gynecomastia is very common, and pubertal gynecomastia is the most common part of it. So, what is the natural?
Yeah, as Dr. Purnima mentioned that it typically happens when testicular volume reaches around 8 to 10 ml. During this stage, testosterone is a bit borderline, and majority of it is converted to estrogen, and the boy develops gynecomastia. But whenever testicular volume reaches 16 to 20 ml, that testosterone becomes so high that it nullifies the effect of estrogen, and then there is natural resolution of gynecomastia. But during this time, if the patient becomes obese, then the extra fat deposition will remain there. So there are chances of persistent if the patient gains weight. Otherwise, pubertal gynecomastia, which is present in 30 to 35% of the puberty going boys, it resolves automatically by 8 to 12 months.
Okay, okay. Thank you for that. And that's some important points you put there. Dr. Kakoli, can you please tell us when can medications be used in gynecomastia? Because parents are always wanting to know if medications can be given to reduce it. And if not, they lastly want to go for surgical interventions. When is that indicated in this condition?
Yeah. So the gynecomastia in puberty or in adolescence is mostly physiological and they typically resolves by 6 months to 2 years. So we must reassure. But the pharmacotherapy like tamoxifen, which is a selective estrogen receptor modulator, is we use when the gynecomastia is very painful, when it's very rapidly progressive, or it is persisting beyond 6 months to 1 year. And if the gynecomastia is causing the significant psychological disturbance, and if we can consider when it is very severe, but the adolescent is not fit for surgery or they refuses surgery. These are the mainly indications when we use this. And among the options of the surgery, there is a subcutaneous mastectomy along with liposuction. So surgery we consider when it is long standing, that is the persistent fibrotic gynecomastia. The medication tamoxifen works mostly in the early phase when there is a glandular proliferation. But when this is a fibrotic, then it is very less likely to resolve by medications. And when there is severe psychological issues, and if the gynecomastia is very severe, like if it is grade 3, and when the patient prefers surgery.
Great, great. I think gynecomastia again is a confusing topic, very common question that we face and see in teens and adolescents. With these three questions and the expert answering it so well, I think we've clarified a lot of those doubts persisting in the minds of all of us. With this, we have a few more questions in the panel discussion, but we'll end it here because we want to give Sudha ma'am also enough time. I
Yeah.
would like to thank you all for being part of this panel, all the panelists, and I will give a small take-home message. We've already been discussed so much about all of them that we got a take-home message in each of them very individually. And thank you, Dr. Tarini, for being there and also giving us your opinion as a youth, what you think are more common adolescent endocrine problems. And again, thanks to my co-panelist. For hosting it, Dr. Malvika. I will introduce Madam Sudha Rao, Madam, who is Professor of and Chief in the Division of Pediatric Endocrinology at BJ Wadia Hospital in Mumbai. She's also Consultant of Pediatric Endocrinology at Tata Memorial Hospital and Jupiter Hospital. She's a very well-known and experienced pediatric endocrinologist with many publications and also a very well-known across the country. I would please invite you, Madam Sudha Rao, Madam, and Himabindu, Madam, if you want to say anything
Yeah.
for the Madam's talk.
Thank you, Dr. Rahul ji. I think that was so wonderful. And all you young pediatric endocrinologists, it was wonderful to see you on the AHA platform. So while congratulating all of you and appreciating each one of you, I would like to invite our Madam Dr. Sudha Rao ji to just talk about a very common problem, what we all face as pediatricians about the menstrual irregularities. Over to you, Madam. We all know you, and we look
Thank
forward. We
you.
were actually looking forward for your session in the
Thank
beginning.
you.
Yeah, please.
Thank you very much, madam. I think I misunderstood that I was told I should join at 9:30. So I didn't understand. I'm sorry. Thank you for giving me this opportunity. And this is the first time I'm interacting with the adolescent group. There is a lot of overlap between adolescents, health and endocrinology, most of it being from endocrine parlance. Can I share the slide?
Yeah, please, ma'am.
Yeah.
Everybody is remembering you, the Gwalior roots, Dr. C.P. Bansal Masar also mentioned, madam. You will look forward.
Chair madam, Sudha madam, welcome,
Yeah.
welcome, madam.
Thank
बहुत
you.
आपके
Thank you.
गाइडेंस में पीजी की मैंने.
Oh, thank you. I think shall we go ahead or?
Yeah,
Yes,
please.
madam. Yes, madam. Yes, madam.
From BJ Medical College, Wadia Hospital, sharing your experience. Yeah.
Yeah, I'm currently at Wadia Children's Hospital here in Mumbai. And without taking more time, I'll directly go to the topic which has been assigned to me today. It's menstrual irregularity in adolescents, an approach for pediatricians. I know it's quite the fag end of the day. It's going to be difficult to hold everybody's attention here, but I'll try to be as relevant as possible through our clinical practice. So when we say menstrual irregularity, how we define that is it's an abnormal, sorry, have I missed you? No. Okay. So it's an abnormal uterine bleeding, which refers to uterine bleeding in a non-pregnant person that is abnormal in volume, in frequency, in duration, and on the cyclicity or the regularity. So any of these components, if they are abnormal, that gets defined as menstrual irregularity. And to understand this irregularity, like I always say, we must understand what is normal. So when we speak of what is normal, we know about menstrual cycle being divided essentially into the follicular phase and the luteal phase. And the talking between the anterior pituitary hormones, especially FSH and LH, and the ovarian hormones, especially estrogen and progesterone, which talk to each other and cause the growth of the ovarian follicle, which then ovulates to produce the egg and then shrivels away to become the corpus luteum and goes into an oblivion to have the next ovarian follicle to come into the cycle. So this cyclicity of ovulation and shedding off of the endometrial lining, and which is orchestrated in the presence of talking of hypothalamo-pituitary axis, brings about our menstrual cycle. So for a menstrual cycle to be normal, we must have the ovarian cycle happening properly, the ovulation happening at the appropriate time, the surge of the LH, the FSH initially bringing about the estrogen rise and which causes the endometrial proliferation as well, the surge in LH which causes ovulation, and then the increase in progesterone which brings about the luteinization of the Graafian follicle and subsequent bleeding and menstruation. So this happens over a period of divided into a follicular phase and then a luteal phase. And this, I think we have all now seen often right from our undergraduate dates. But this is the important basis of understanding what could be the pathology. So when we say pathology in children, like it was pointed out in the previous excellent panel discussion, there is a lot of overlap of physiology in pathology as far as children are concerned. So the interval between menses to be, that is what parents actually worry. हमारे बच्चे का अभी 4 दिन ज़्यादा चढ़ गया, अभी तक पीरियड नहीं आया, और ये 4 दिन जल्दी आ गया. So that is what is the most of the mothers especially, or even the grandmothers or the families worried about. So the interval between menses becomes tightly controlled in the normal range only between 20 years and beyond. There is a wide variability of the interval between menses in the early on in the post-menstrual years. So the cyclicity and the interval fixation usually takes as many as 7 years as well. So if you look at how this goes about, there are these systematic reviews which says that the mean cycle length in children, adolescents could be anywhere between 34.5 days, ranging from 30 to 61 days. And the bleeding duration can also vary anywhere from 5 to 5.4 days. One interesting thing is any child, any adolescent girl who has achieved menarche, say less than 12 years of age, becomes an has ovulatory cycles as early as by first post-menarcheal age, which gets longer the more delayed is the onset of menarche, which is very important for us to understand. That means these days we know menses is happening quite earlier, menarcheal age is coming lower and lower. Their ovulatory cycles are going to happen earlier. So if any child who's got a menarche by about say 11 years and comes at 13 years with some irregularity, you can't say that maybe it's okay, keep wait and watch, and this could be just a post-menarcheal thing. So we as pediatricians and adolescent physicians should be more cued to the concept of the ovulatory cycle setting in earlier in children who have had their menarche earlier. That's an important aspect to understand. When we say adolescents with menstrual irregularity, it can be categorized as absence of menses, menses at irregular intervals, happening at the menstrual period, the duration is also at irregular intervals. It's happening excessively, or there is heavy menstrual bleeding, which gives about a feeling of quality of life related effects, the social, the physical, the emotional, and the ability to interact, material, etc. There could be something like an intermenstrual or breakthrough bleeding. So these are the various forms of menstrual irregularity that we see in adolescents. And to come to some definitions, what do we mean by primary amenorrhea? Primary amenorrhea is when there is no menses by 15 years of age or by 3 years after the onset of the what is it called? The features of pubertal onset, that is thelarche. Secondary amenorrhea is when you have over 90 days without menstrual period. That means something like 12 weeks without menstrual period after initially menstruating properly. Menstrual irregularity is dependent on the post-menarcheal age. If there is more than 1 year of post-menarcheal age, the average cycle length is about 90 days. So an individual could have 4 periods per year. Between 1 to 3 years, there could be an average cycle length anywhere between 21 to 45 days. More than 3 years, it becomes a bit narrower. You have 21 to 35 days. And the third aspect is the volume of the bleeding. So if you have a menstrual bleeding which is occurring very frequently, that is every 21 days, or is excessive, so something like one pad or lasts for longer than 7 days, these could be called heavy bleeding. But what is important for us to understand here, my slide is not moving, is that cycles shorter than 21 days or longer than 90 days are abnormal at any stage of life. So if you take a detailed menstrual diary history, and if you find any of this, these children should be red flagged and seen what is going on. Persistent abnormal menstrual bleeding for 1 year carries an approximate 50% risk of ongoing menstrual irregularity, and which could likely turn out to be PCOS subsequently. So what questions do we ask in the history when a child comes to us with menstrual issues? One could be to start off with age at menarche, which is very important, because like I said earlier, age at menarche is associated with shorter time to establish ovulatory cycles. The menstrual pattern, that there comes the importance of maintaining a diary where you allow to classify the etiology based on the type of menstrual irregularity the child might be having, and is there any event which coincided with this particular menstrual pattern, especially sudden onset, say weight loss, stress, something like an intensive exercise, these size 0 adolescent body image related issues, breakthrough bleeding if it's coinciding with any initiation of hormonal contraception, head injury or hypothalamic dysfunctions. So these are some etiological questions which can be derived in that history. When did the abnormal bleeding start? What must be the etiology? Heavy bleeding at the onset of menarche. Suppose there is soon after the onset of menarche or at the onset of menarche there is heavy bleeding. There could be hematological cause rather than an endocrine cause of a bleeding disorder. And these days, more and more adolescent girls are becoming what is it called, sexually active. So if there is any if there is any contraceptive measures they are following, that should be taken into account. Past medical history of medical illnesses, especially chronic kidney, chronic liver, rheumatological disorders, and diseases which affect the hypothalamo pituitary ovarian axis should be taken in the medical history. Medications, aspirin, valproic acid, and medications which affect the HPO axis, especially the antipsychotic drugs, etc., antidepressants should be taken into account in your history. Then when you look at review of the symptoms, like I said, presence of bruises, any apparent bleeding, excessive post-op bleeding, von Willebrand disease would be one important cause which presents as menorrhagia. Orthostatic hypotension, weight change, these are your objective clinical findings which you can take up. Abdominal pain, vaginal discharge pointing towards PID or endometriosis, dysmenorrhea, galactorrhea, headache, visual issues point towards an underlying problems endocrine like hyperprolactinemia, pituitary dysfunction syndromes, PCOS, etc. Changes in bladder bowel function, which could give you an extrauterine bleeding like hematuria, abdominal masses can be palpable, joint hypermobility, hyperextensible skin, abnormal, all these things could be the associated review in terms of systemic signs and symptoms which you would take in the detailed history. Family history of heavy menstrual bleeding sometimes goes underdiagnosed. It's always good to ask the mother as to what is the kind of menstrual bleeding you have. Sometimes it goes in the familial also. Family history of associated disturbances you can ask for. So stressors, I would like to press upon the social stressors, exam stress, body image related issues, severe exercise pattern, gymming, going to gym, all the substance abuse, all these are very important social factors or should be taken in the history to figure out whether any of these are the underlying culprits because they affect the HPO axis. So coming to one of the cause, which is primary amenorrhea, when a child who's more than does not have PV bleeding by 16 years of age, it's good to look at whether there is no menses in the presence of no breast development and absence of uterus, which points towards the spectrum of DSD disorders, or whether the breast development is not there but the uterus is present, which could be a delay in puberty, constitutional delay in growth in puberty. It could be a gonadal failure syndrome, or there could be a gonadal dysgenesis. There is a presence of breast, but you couldn't find a uterus on your pelvic sonography. It could be an aplasia like Mayer-Rokitansky-Kostner syndrome. You can have a complete androgen insensitivity syndrome where again the Mullerian structures would be absent. You could have the presence of breast and uterus, but still the child could be amenorrheic in presence of functional hypogonadism, which could be psychological, which could be exercise induced, which could be because of chronic illnesses, or any hypothalamic dysfunctions which could be present in these children. So what clinical evaluation would you want to do? You would like to, as soon as a child comes to you, you would want to see the hemodynamic stability, and urine pregnancy test is mandatory. I think we should be upfront and be able to check that. Check the height, see for short stature. Hypothyroidism, one important condition which was discussed previously, can present with a very varied kind of PV bleeding and not a true onset of menarche. Non-congruent pubertal features. That means a child comes to you with only menarche, PV bleeding, but does not have any breast, does not have any pubic hair, is a bit odd. So, or you have no pubic hair and just breast development and menarche, again is not the congruent way of the pubertal progression that happens. Presence of obesity, like in this girl with this acanthosis nigricans, which is there in this picture, pointing towards insulin resistance syndromes, can present to you with menstrual disorders. Then you have the androgen excess features beautifully pointed out in the previous discussion, and features of any systemic illnesses, chronic anemia, thalassemia. You have hepatosplenomegaly, you have a feature of, say, chronic inflammatory disorders, but inflammatory bowel disease, anemia, lymph nodes, syndromic features, all those things you would want to see on examination. So this modified Ferryman-Galloway score was told as a discussion previously. This is how you do the scoring system, and more than 8 is supposed to be hyperandrogenism, hirsutism, which is the indicator of hyperandrogenism. Severe acne, inflammatory acne is much more sinistrous as compared to non-inflammatory acne. Inflammatory acne indeed points towards a high level of androgen, and that is the feature of that. And you would have other equivalents in the form of balding, seborrhea, hyperhidrosis, etc. So when you have a child who's short and comes to you with menstrual irregularity, there is a breast there, and this child has even retarded bone age, the underlying diagnosis was of hypothyroidism, and that needs to be corrected, wherein the pubertal issues also get resolved. So what investigations we do? It's important to, like I said, do the pregnancy test, the coagulation profile and factor assays, hemoglobin levels, do an evaluation for psychological stressors, which we always think as a diagnosis of exclusion, rather, meaning come to that after we exclude organic causes for sure. But then that is a very major underlying disorder, which I think we should check upfront as soon as a child comes to you with a menstrual irregularity kind of a condition. So in PCOS, I think this is the endocrine spectrum of disorders where all these tests are done, and that has been spoken in the previous discussions. I'm not going to do this. And we know that pelvic sonography is useful in looking at the ovarian cysts and the morphology of polycystic ovary, but there are caveats to this that was again discussed in the previous discussion. So how do we look at what to do in terms of menstrual irregularity? One thing I would like to say to all adolescent physicians and pediatricians is we should not label children with menstrual irregularity to have PCOS. That much is 100% agreed upon, because there is a lot of overlap between the physiological transition to indeed a pathology there. But then it is important to, based on the consensus guidelines, it is important to understand that labeling hyperandrogenic adolescents as having PCOS, if menstrual abnormality has not persisted for more than, say, 2 years, should be done with great caution. And they should be called as children as at risk for PCOS and should not be labeled as PCOS, which sometimes these adolescent girls They overhear, they go Google, they know that there is what is this PCOS, and even the parents, mother especially, it creates a big havoc, which itself gives you a kind of hardship to manage these girls. So this is a approach to management which has been taken from a Western literature. You need to be able to look at the bleeding categorized into mild, moderate, and severe. We would look at only mild and moderate. I would expect severe ones either go to endocrine people, or you give the emergency management and then refer to, I would say, endocrine, but often they all go to gynecologists as well. So once you obtain the baseline, if there is a mild kind of anemia or mild kind of symptomatology present, then you need not start any particular type of drug. But if it is hemoglobin which is low, you may look at iron supplementation, of course, and people do use triaxanimic acid to prevent that bleeding, which is like a temporary management. But hormone therapies form the backbone of treatment when you have moderate to severe forms of ovulatory bleeding disorders. And what we commonly use is medroxyprogesterone acetate alone in the absence of hyperandrogenism feature, which is a different spectrum. The PCOS, I'm not talking about PCOS at all. When you have a hyperandrogenism, you need to give a combination of anti-androgen with your estrogen pills. But medroxyprogesterone acetate is a progesterone which can be used to take care of the bleeding in a controlled manner for X number of days each cycle. But we would like to not have lot of these girls going on into these any kind of pills. At the same time, depriving them of the pill combinations would also have its own effects. So there has to be a considered decision making as to which of these girls would need any of these estrogen progesterone combination pills to be given. And I guess it is best done in the presence of a specialist, maybe. So to sum up, the key messages is physiological, in terms of menstrual irregularity in adolescents, physiological processes overlap pathology, and bleeding disorders should always be evaluated in these girls. And detailed hormone evaluation is required in less number of cases, because often it is the physiological maturation that is being seen as the referrals. Hormonal treatment is to be undertaken only with expert opinion. Thank you.
Thank you, Sudha Madam. And that was a pleasure to listen to you. Madam, as we all know, she is from our division of pediatric endocrinology from Vadia Hospital. And many of us are students, colleagues to her. And all of us were remembering you, Madam, as I already said. And she's been a
Thank you so much,
yeah, from Tata Memorial Hospital and consultant pediatric endocrinologist with a lot of publications to her credit. And it's really a pleasure to hear you, Madam. And some of the questions, I think today with another 2 minutes, we may take these questions. Dr. Rahul, would you like to facilitate this answer? Because I also requested all the panelists to be still stay on. There were a few questions in the chat box.
Yes, ma'am. Just going through the questions. Actually, yeah.
Madam, you can please involve Madam also, Sudha Madam, who was patiently waiting actually for us.
Dr. Malvika, I'm not able to scroll. Can you just scroll and just discuss with the panelists, please? Yeah.
There was one question on how to manage isolated thelarchy in an 8-year-old girl when all other parameters are normal. Sudha Madam, would you like to take this up?
Sorry, isolated thelarchy.
How to manage isolated thelarchy in an 8-year-old girl when all other parameters are normal.
So in short is wait and watch. Call her again after 4 months to see is there any pubertal progression. When you say all parameters are normal, I presume that the bone age is not advanced. I also presume that the child is not tall. I also presume that your hormonal evaluation is not like a true activation of the axis. Sometimes you need the GnRH analog stimulation test. And isolated thelarchy these days are very common. and they do go through their own progression timetable. Isolated thelarchy does not mean early menarche. That's what the epidemiology also says, the prevalence rates also say. Though the age at thelarchy has become younger and younger, the age at menarche has not become really very young, has not become really less. So there seems to be a slower stuttering progression of these pubertal characteristics in these children. So monitoring is important. Every 4 monthly, looking at their heights, progression of pubertal features are important. And there are many environmental disruptors which have to be taken into account in our current social kind of life, social life of plenty. So, though there are no cause and kind of effect evidences there, but arginine in many of your what is it called, milk powders which you use, the additives, and then the lavender we all know, soya products, flaxseed, phytoestrogens which are coming in various forms. Those are some of the environmental additional factors. I won't say disruptors, additional factors which which can be easily told about and taken care of.
Then one question from Shefali: why are we not treating menstrual irregularities in adolescents? Are we not treating?
I don't know what the context of not treating is. If the child is in the early postmenstrual age, like I mentioned, no, many of them could be anovulatory. If those bleeding features and cycles are anovulatory, we need not treat them. The axis will settle down over a period of time. Just see to it that the baby child doesn't become very pale or doesn't need any other help. So
Right.
we do it, but it's
Yeah.
not like.
I think Zalak or somebody in the panel was discussing about the drugs doses, and there was Shanti Lakshmi asking us, what is the dose of orlistat?
Yeah, Dr. Kakali, I think was a
Kakali,
question
sure.
about, yeah. Dr. Kakali, if you're there, if you can answer that.
Anybody else can take up if she's there. Zalak, yeah, if you want.
Zalak, Dr. Zalak, are you there?
Yes. So, Orlistat, what we have seen is it's not very effective. And the adverse effects which we see with Orlistats are quite disturbing, like oily stools and sometimes staining of the undergarments with oil and GI disturbances. So, though Orlistat can be given in children because rest of the other drugs are has to be used after certain age. So Orlistat can be given started with 60 milligram 3 times a day up to 120 milligram 3 times a day. That is how it can be given. This is the dose of usually this is how we give Orlistat in children. But my experience will be it is not very effective when we talk about use of Orlistat in obese children.
Right.
Sudha ma'am, if you want to add something.
Yeah. No. So when you start making this into a disease, obesity becomes a disease, and you start prescribing drugs, you lost half the battle, maybe the whole battle. So the thing is to impress upon lifestyle changes, the dietary issues. I don't think we should refrain as far as possible from prescribing any drug unless there is comorbidities present. Comorbidities could be steatohepatitis, it could be hypertension, it could be dysglycemia. So when you have comorbidity, you have a reason to prescribe drugs. Otherwise, lifestyle and diet, that would be the way to go about. Yeah.
Yeah, thanks, ma'am.
Yeah,
We
I
have
think all the
another-
panelists and experts here. Yeah. Rahul, you want to add something?
Yeah, ma'am, just taking the next question. Please, ma'am, continue.
Anything you are saying? No, I was wanted to know from all of you. For the young people, we are all as part of AHA want to go down there to the schools, colleges, tell to the next generation what to do. Really, so scary it is with you mentioned about this, disruptors. So, what are the precautions, preventive measures? Some of the things are not in our hands totally. So what we can do with present climatic changes, radiation exposure, so much of adulteration in the food, lifestyle, when we say what changes, preventive measures we can take and what message we can give to our youngsters. Maybe all of you or maybe some of you. And of course, I'll ask Madam Dr. Sudha.
I think avoiding totally is not possible nowadays. You can just reduce the exposure to endocrine disruptors, but avoiding it totally and I don't think that's possible in our day-to-day life. Sudha ma'am?
Yeah. So it's almost like going to Mars and living or whatever because because it's there everywhere. The disruptors are there everywhere. So sometimes I don't know whether I'm correct or not, but when I talk to parents, I say, do what your grandmother or mother did to you. Continue that kind of life, because now you have these soya flakes, then you have momos, then you have burgers, then you have pizza, you have everything at the even the small 1-year-old can order these from the mobile phone. So that is how easy it is to access all this. So it's a difficult task. Once they all go out, now that with 50% tariff rates or whatever rates Trump government has applied on, I don't know whether these things will become more expensive in India, out of reach of the commoner. So there has to be some drastic change, but we can't stop living, I suppose. I think we need to take it.
Makeup, I believe, also in these days,
Yeah.
adolescent girls use a lot of makeup, so that also is very harmful, has a lot of endocrine disruptors.
True.
Purnima ma'am,
So,
there one small question for you if you're there. Is unilateral thelarchy always pathological? Was asked by Dr. Shubha. So, if you're there, if you can let us know about this.
Usually, breast enlargement happens unilateral and sometimes bilateral as well. But if it's persisting beyond 6 months, then if it's painful, then we have to look at the other local causes. Otherwise, it's
Yeah.
common to be seen unilateral.
Yes, ma'am. It always starts usually on one side and then progresses to bilateral. But sometimes local causes could be some hemangiomas or something else like that could also be there. Some other local things also is the important thing. Also, there's a question about 9-year-old girl with breast development, again, very similar, unilateral at 9 years with other secondary sexual characteristics not yet developed. Like Sudha ma'am said, it's important to see if it's progressive or non-progressive and look at the pace of pubertal progression, look at the bone age, and then follow-up is most important for these children. Generally, 9 years is normal for having thelarchy. It generally starts with unilateral and goes on to bilateral. So, if at all follow-up is normal, this gradually progressive puberty with not less than 8 years that it started, then it's completely fine. That was other question which is there. So I think most of the questions are answered. Can you find something else, Himabindu ma'am, that we've not answered yet? Or should we?
yeah. So, yeah. So it's time to, I think, little wind up with some key messages. So what is the key message of today's webinar? Dr. Rahul, 1-2 liners?
Yeah, so the main thing would be knowing what is normal and what is abnormal. Adolescence is an age group where children transitioning from childhood to adults, and we know that a lot of mix can be there from normal, benign to pathological things. So recognizing those things in PCOS, which are normal, which are not PCOS, the menstrual irregularities, which can be normal. Also recognizing hirsutism, when to recognize the danger signs, the warning signs. Children who are short in adolescence, when is it a red flag? We've discussed all that through this webinar. And also regarding puberty, which is so common now, having early breast development in girls. We've discussed that very extensively. So I think that is what we want to mention, that a lot of things we should treat them as normal, will need follow-up, which need certain investigations to rule out secondary causes and more dangerous pathologies that way.
Thank you, Dr. Rahul. I think we should also thank Dr. Sudhir Mishra, sir, you are still there, our scientific chairperson of our IAP-AHA. I know it was he he initiates the process, and then we all fill in to select most beautiful faculties from across the country. And each one of you was so excellent, so amazing. And you all look so young, yeah, all of you, including Madam. So really hats off to you. And I think all our pediatricians still are there in the late night at 11 o'clock. We still have about 60, 70. And thank each one of the delegates who have actually joined our webinar. The super specialty webinars, I hope they're useful to our pediatricians. And Dr. Rahul, you have been wonderful. You have just moderated the session so well, along with Malavika. And thank Zalak, Dr. Chetan, Dr. Punima, and of course, our young voice, Dr. Tarani, and of course, Sudha Madam. So much thank you, Madam. In spite of a busy schedule, you have accepted to be with us, and we look forward for further collaboration with you. And in terms of research or anything else, AH is open for it. Thank you, one and all. Arya sir, a formal one note from your side. Sudhir
मैडम
sir,
आपने तो सबको थैंक यू बोल दिया है।
जी जी
फिर भी एक फॉर्मल वोट ऑफ थैंक्स देना
सुधीर
चाहूंगा।
सर क्या
आई
देखते
एम
हैं सर,
थैंकफुल
बिकॉज
टू
सर
ऑल।
सुधीर मिश्रा सर
हाँ, सुधीर मिश्रा सर,
डॉक्टर स्नेहा मैडम, अरे मैडम भी है।
हाँ स्नेहा मैडम, रश्मि गुप्ता मैडम,
स्नेहा
डॉक्टर
मैडम
सीपी
आप बता
बंसल
दिए
सर,
वोट ऑफ
सब लोगों ने सुधा मैडम को याद किया आज। मैडम से मिलने के लिए सब लोग आए थे। मैडम नमस्कार।
मैडम की आवाज सुन लेते हैं सर।
हाँ मैडम, आपकी आवाज सुनने के लिए डॉक्टर सीपी
वोट ऑफ
बंसल
थैंक्स
सर
आप
सबसे
बता
पहले
दीजिए।
आ गए थे।
Yes, very happy to see Sudha madam here today.
Right,
I am
madam.
really delighted that she has imparted her knowledge and made us more vigilant and more careful for diagnosing the things. We should not jump to the diagnosis and we should follow the patient and we should approach gradually, not jumping to the PCOS or menstrual irregularities, and should not be treated very drastically. We will thank to all the speakers who have given beautiful knowledge which is really useful in day-to-day practice, and definitely all the pediatrician will be getting all the benefits of the today's topic. And it's the real vision of Madam Hemabindu Madam, who she selects the topic so well that everybody sticks to the television and the this thing screen till the end, because the topics are really interesting, really interesting. Thankful to all the dignitaries and the attendees for the session. Thank you very much.
Thank you.
I am also very happy to see Dr. Sudhara after a very
डॉक्टर
long
जेसी
time.
गर्ग सर, डॉक्टर
Girg
जेसी
sir.
गर्ग सर।
I am
I
also
didn't
very
know so
happy
many
to
of you all
see
do
Dr.
adolescent.
Sudhara
That is
after a long time.
अरे सब
She is
एडोलेसेंट हो गए
a
ग्वालियर
Gwalior
की।
product.
रश्मि मैडम,
Hello, Sudha.
कितनी
It's
प्यारी
always
से बुला रही है।
pleasure to see you. And she was
हो गया बस।
always an academician at
बोलना
our
हो
place.
गया।
You know, she's my junior. You know that, and she used
अच्छा।
to teach us. She was so
Oh.
intelligent.
Please let it not. Thank you.
मैंने रिकॉर्डिंग बंद करवा रही हूँ मैडम, वी कैन हैव सम
बस
फॉर्मल टॉकिंग
रिकॉर्डिंग
सो
बंद कर रहे हैं।
या